think one of the other things that we've learned about was each other's area of specialty, that from a palliative care perspective, the projects let us understand learning disabilities better and some of the issues that we might encounter when we're seeing patients or families. And I think for our colleagues from a learning disability background, it's helped them understand maybe some of the symptom management stuff or the kind of end of life things that they didn't feel as comfortable with. And I think having the two sets of specialties there has been really good, and we've learned from each other from the formal education, but a lot of the stuff has come from the discussion. And having the support of one another when we're coming up with individual patients or families that we've got a query with. Now we know who's out there and can know it's
it's pulled everything together. I mean, myself, I didn't even know learning disabilities team existed, you know, so that's really, really good.
A good discussion that we had earlier about the DISTAT as well.
We rolled that out to the nurses within our units in the palliative care wards, and we found it invaluable because nobody had any knowledge of it. We didn't realise when patients came in how to recognise what they were like before they came in. When they came in, they were actually quite unwell, so it was really, really helpful for us to identify what they were like before and use that as a good tool for assessment. So.
Actually gave education sessions before, but I did go back to the hospice, and I've given out education sessions to all the nurses there, and they really enjoyed it. They're really good. You know, they took it back to the wards.
It's been a really good mix for the patient, that those of us key practitioners who come from a palliative background to learn about the learning disability stuff that we have never had the opportunity to be aware of, and just to recognise how much there is out there, and hopefully for the LD nurses as well to get a better grounding on palliative care issues. And I think either side, each professional is probably a wee bit scared of the other topics, and I think that's broken down a lot of barriers and helped us to forge professional relationships there as well. Medical stuff that we did recently, and I think that was really challenging for all of us, because it didn't depend on your background being palliative or LD. You know, these are kind of situations that we could all come up with, and there are different paths and different options, and I think understanding that there isn't necessarily a right answer here, but it helps us kind of clarify our thought processes. So that the ethics side of things, that was really informative, but also just the general understanding about, you know, from a learning disability perspective, that these patients are often sidelined, and you know, they don't go for screening, but equally there are certain LD diagnoses that make people more prone to a particular cancer, and you know, that's not something from a palliative care perspective that I would have known about before. So even helping to understand that depending on what's wrong with the individual can make it, you know, for example, maybe esophageal cancer more prevalent, or some other disability. You think, well, okay, that's starting to make sense professionally when we're getting these patients referred to.
Certainly one of the things that I've noticed from the pathway that I think that would benefit our client group within the general hospital setting would be this is what matters to me, but because I think that gets missed. And certainly if there was something that was, you know, very visible, you know, because we realise how busy nursing staff can be, but if we can get the most important things that's important to each individual, then hopefully, you know, that these needs could be met during their stay within hospital.
I think one of the areas that I have learnt a lot from with the pilot study has been just about anticipatory care. With the lady that I've recently been involved in, we had our first sort of anticipatory care meeting, which meant that the person's next of kin came, who's power of attorney, the provider and medical staff and various members from the learning disability team came to that. And it was really good. So just a wee bit about what you were saying, what matters to me. And this lady, for the past few years, has put her own wishes in for her future, and that has now been documented in her care plan. From the very personal area around bereavement and cremation, to a will to who she wants to be able to support her at the end. So that's been a learning process for me in all of this, and how much insight the client had as well in all of this.
My name's Anne Bradley and I'm the ward assistant at the Prince and Princess of Wales Hospice.
And my name's Rosemary McGinley. I'm a healthcare assistant at the Prince and Princess of Wales Hospice.
Both myself and Rosemary have been involved for the past 3 years as key practitioners with the building bridges, looking at patients with learning disabilities and who have palliative care needs. This is an area which probably we didn't really see enough. We hadn't a lot of referrals with patients with learning disabilities in the past. We maybe had an odd person, but I think doing the project has actually helped us. And I think particularly Rosemary, the patient that we had in just about 2 years ago originally, was a 19-year-old boy who came into the inpatient unit who had cerebral palsy. And I think his first admission was quite fraught in that the staff weren't really aware of how to take care for his needs, and I think that was just because we weren't used to dealing with patients with such profound needs. At the initial, the first admission, we really relied on his mum for a lot of the information regarding this patient. But I think from doing the project that really helped us to do better assessment skills with using DISTAT. DISTAT was a tool that we'd never heard of before, and we felt that by getting the education towards using this tool, we were able to use it quite effectively. So I think on the first admission when we used the DISTAT tool, we didn't know what we were actually doing with it. We had not a clue, and I think the first drugs round I was looking at this assessment and thinking I'm not quite sure what we do here. And I think through doing the educational programmes and working with the community teams from the learning disabilities, that really helped us.
When Jonathan first came in, found that his mum wanted to do everything for him. Obviously she's protective because it was her son, but she did get used to the staff that was caring for her son, and that really helped us, and she helped us a lot to look after Jonathan. And we built up a good communication when we were working with Jonathan as well, but his mum really helped the staff quite a lot.
I think joint working has really helped us. I remember to look up the resource pack, the A to Z resource pack, and then you can find out who is it you need to contact, who's in that area, and you've met them before, so there's not really any problem with doing that, so that's always better. We usually, that's something maybe we wouldn't have done before, so it has changed our practice a bit.
I think getting together has been one of the big things, because knowing the faces, getting to know the faces, I mean, you know, at least you could lift the phone and ask over the phone if you needed to do an urgent joint visit to see someone, ask, you know, your advice and expertise, and you can arrange it quite quickly. Whereas if we hadn't all got together to get to know each other, then it would have been more difficult to do that, I think.
And the other thing is we are working as key practitioners, but in our area we're taking that back into the area as well, so our other colleagues are getting the benefit of that. They've got the resource back there, they've got us to use as a resource, and they can, there's 2 of us in Marie Curie, so we're going to be talking to each other. If one's not there, the other one's there, and they can come and ask.
I think the most important thing about the project is the networking, and because we've all came together and we know we can tap into each other's resourcefulness and expertise, so that we can provide the best holistic care to the person that we're looking after. So it's the whole team working together as a whole.
It makes you think about your own practice as well. And my experience in palliative care before was, it was like I just always used to think it was the GP and nobody else, until we got together as the pilot, and you learned that palliative care wasn't all just end of life care.
That's right.
It was also about like the prognostic indicators that, you know, someone went into hospital and came out a wee bit less able than they were before, constant hospital admissions, I would never have put that in the palliative care banner, you know.
So you understand the journey better?
Absolutely, and I think that has made such a difference.
And I would quite honestly have felt out my depth an awful lot of the time if I was out to somebody with, especially with a severe learning disability. I just wouldn't know where to start with assessing them. And now I've got the bonesy in assessment. I might not be fantastic at doing it, and I might need some help with doing it, but I would know where to start, and I wouldn't feel terrified to go out to see somebody anymore. I would say, well, that's fine, I might not be able to do it all, but I'll get somebody
That's
that'll
got that,
know that
the
kind
skill.
of expertise that's here, and I'll help them with the symptom management stuff that's needed. So no, I think it can work really good. I think it's a great project.
I think one of the things for me is the confidence that you've got now, because you've learned quite a lot from your palliative care colleagues. You've got the confidence to challenge GP's decisions in terms of people with learning disability, because a lot of times challenging behaviour is put down to their learning disability, and it might not be an indicator that their health is getting poorer, and I think that's one of the things that I've learned. I've got more confidence to challenge GPs now.
I think the main thing is gaining confidence, and because you've got the support network there, you've got confidence in looking after the person better, whereas before you were maybe in the dark,
and
you were on
isolated.
your eye, and you felt helpless a lot of the times because you didn't have the understanding of learning disabilities when you're working in palliative care. But now we can tap into the palliative, the learning disabilities team, and they've got a better understanding of the person and their needs, so that lets us all help them better together.
And likewise for us, we had no knowledge of the pain management and the drugs used and you know, that kind of thing, and how you can adjust the pain medication. So that's been a real help for us. And again, it's people's expertise in using that
And sharing that with each
and
other.
sharing that. Yeah, absolutely.
And at the end of the day, that you can, you know, you feel that the person themselves and their families are getting more supported and more help, because the two teams that work together is one big team. We're all working together for the best.
So it's a coordinated service
person.
for the client.
Yes.
Yeah, absolutely.
Yeah,
So-
huge benefits. Definitely.